finger beds and fingernail beds, and he's got a sternotomy scar too. Uh-oh. Okay, he can't talk to you. He isn't too much distress here, but already we're starting to put some of this together. That we've got, probably he's had some kind of coronary surgery, but he's on hormone 2. What are we going to do? And as we get his capnography, this is, if you look at it, it's really, that's kind of a shark fin pattern, okay? He doesn't have the rapid upstroke with a leveling off. It keeps on sloping up to a point because he's trying so hard just to get her out of his lungs. He's another variant of, and let's face it, this is a large part of our business in the EMS, a variant of the very first case that we reviewed here. You give him albuterol, and now we start getting nice square forms. Okay? But it's somebody who, well, we know he's got potential coronary disease. We don't want to get carried away with our treatments, you know, how much albuterol we give him. It's a really good way to monitor him. Clinically, they'll expect to see some nice improvement at this point too, but hopefully they'll get started talking to you. Okay, trauma. This was Christmas Eve, really nice grandfather coming from Cayucas towards Morro Bay, and in his Camry, and a drunk in a big truck pulls out right in front of him, okay? He was wearing a seatbelt, so you can see the nice seatbelt strap here, and he's brought in, pulse of only 76, but uh-oh, his blood pressure's 80. Got to help patient. What the heck's going on here? Well, this was a little down the line. He's got an ET tube down, but take a look at that mediastinum. It's wide. It's huge, right? He's torn his aorta. He's also got a clavicle fracture right there. You can see the clavicle broken from where his seatbelt was. This was major impact. Torn his aorta. He's not perfusing his tissues well at all. Apparently his heart's not doing well either. He should be much more tachycardic. And this is profound shock, okay? So even though we were ventilating him quite well, this is the type of capnography we were getting. What are we there? We're less than 25, all right? Is it that we are not ventilating him adequately? No, we were. It's just a profound shock state. Unfortunately, somebody in their late 80s, this kind of injury, I had them all packaged to go to the operating room, and fortunately, the OR team told me, what do you think you're doing here? And I realized they were right. We kept them comfortable. But other things that would cause this, we said low cardiac output. There's lots of states that will do that. This is traumatic shock. Septic shock also will give us low metabolic rates with low CO2 and hypothermia. All right, now we're going to wrap this up with an interesting case. Dean, I included this for fire services. Okay, this was before. It was quite a while ago, before I had a digital camera and before we had capnography. And I learned a lot from this case. She was in a closed space. It was a flash burn from propane, actually. And it actually ignited everything, but unfortunately, superheated gas. She inhaled it, and take a look. What do you see about her? Sure, she's got singed eyebrows, eyelashes, and hair. Take a look at her nose. Really burned right there. She's taking a breath right in the superheated air. Gases went right to her nose. And look at her lips. They're really scorched too. She had her mouth open, okay? So we've got potential for an airway burn here. And this is every bit as scary as the lye ingestion that we showed you earlier. What do we have to look out for here? Now, you want to paint the picture. I did not have capnography back in those days. What would I have to do to know what her CO2 was doing?
Blood gas.
Yes, all right. So, I hate to tell you, anybody who's at blood gas, you just dated yourselves. Because the medics coming out of their training now are going, what's a blood gas? Oh, it's embarrassing. And how long does it take to get a blood gas? If I've got a really good RT tech who can quickly get into that artery and run to their lab and run really quick for me, maybe in 10 minutes they can hand me the blood gas. And what that is a direct measurement of oxygen in the bloodstream. Well, pulse oximetry already started making blood gases obsolete, but we would still do them for CO2 on occasion. And this was when I really needed it. Okay, she's working hard to breathe already, and I need to know what her CO2 is doing. So the numbers I'm going to give you were based on blood gases, and in retrospect, I so wish I had capnography for hundreds of patients that I've taken care of in my career previously. What's going on? Her early pattern would have looked like this. She was wheezing. She was already wheezing at this point, and this was not strident. And a tip that I always give my students, you can use it in the field too. If you're not sure if it's upper airway or in the lungs, listen to the lungs and then hold your stethoscope in front of their mouth. And if you hear the same sound in front of their mouth, you know it's upper airway. It's going to be stride or it could be coming from their larynx. But if you don't hear it there and you don't hear the wheezing in the lungs, you know it's coming from the lower airways. And that's what we had in her case. So though she had these burns up here, I knew that we actually had a lower airway burn going on and bronchospasm developing. Well, capnography could have told me that right away from this wave pattern, all right? She's got the shark spin pattern. She's having already trouble getting air out of her lungs. Let's go through the basic vitals, okay? O2 sat, I did have it in those days, was 88%, and we're trying to give her 100% of humidified O2. Her pulse is 112. End-tidal CO2 based on what came back to me actually 10 minutes later from the pulmonary lab was 25 millimeters of mercury. So that tells me she's working hard. She's hyperventilating, okay? So it's not a problem with air moving that much at this point, it seems. But her respiratory rate is 30, and we've got diffuse wheezing. As we follow her, and I start trying to give her some albuterol, try to get her stabilized. I've given her all the oxygen, humidified oxygen I can, and oh good, I'm making some progress here. Yay! The O2 sats improved to 90%. Not bad, Paul. Okay, well, the pulse is up 128, a little bit more. Boy, she, though, is not looking good in that she's getting restless. That's a hysterical patient, right? She's starting to thrash around now, getting agitated. And respiratory rate's just the same. In fact, her wheezes have decreased. So we're all giving ourselves high fives now. She's doing great. Until the repeat blood gas comes back showing 33. Oh, now I'm in trouble. Actually, this tells me that she is actually decompensating. This CO2 is such a better indicator than the oxygen saturation ever will be of how well she's truly ventilating. We've probably got pulmonary edema now starting to fill up the lungs. The wheezes decreased because she's not getting better. She's getting worse. I mean, what's the worst asthmatic you're ever going to treat in your careers? It's that young one with the silent chest, not the wheezing one. Okay, that's the one that's going to die on you. And she's going down that pathway from an airway burn that's quickly decompensating. And if I had had capnography at that time, I would have been 10, 15 minutes ahead of the game, or even more. Instead, I'm waiting for blood gas to come back. Yeah. She's becoming uncooperative because she's getting acidotic. Even though that CO2 looks low, she's actually having problems truly ventilating, clearing CO2 out, and she's decompensating rapidly. If you look also, the shark fins are coming a little closer together now. She's actually starting to work faster and faster to breathe. The respiratory rate might be going up, but perhaps the tidal volume is going down. She's having a harder time moving the same amount of air. Again, capnography can be life-saving in these cases. This gal in the end ended up doing all right, but I was way behind the curve. I shared this case because at our last session, we reviewed an asthmatic, a well-known asthmatic from the South County, and I'll just try to summarize it. Was everybody present who was involved in that one? It was the medic. I have to compliment him. I mean, he saved her life, but at the same time, he was such a frightening case because there was no appreciation of just how sick she was. And again, it was an asthmatic, same kind of vitals, same sort of presentation, well-known. We get here all the time. She gets kind of hysterical. We give her some albuterol. Wheezes are decreasing. And she's got an capnography is showing a PCO2 of 25. Huh. That's kind of bad, right? Good. We give her albuterol, her wheezes decrease as we're transporting her. Her capnography is getting up into the 30s. Yeah, all right. No, this is actually bad news. It means her ventilation is getting worse. And he doesn't understand why she's trying to pull her mask off, why she's getting agitated. And suddenly, as they place her on the ER gurney, they're doing a crash intubation on her. And fortunately, the patient did well. Now, he's beating himself up over this. I'm telling him, if you hadn't given her albuterol, if you hadn't even given the O2 that you did in the field, she wouldn't have even made it to that ER gurney. He saved her life. But capnography would have made us even more appreciative of just how she was decompensating despite our best efforts. I wanted to share this particular point with you because of all the cases that so far I've seen us using capnography, and this is probably the most instructive. And Jessica touched on it right at the beginning, asked that question about the low PCO2 can actually be the patient who is working the hardest. They're actually moving a lot of air maybe, but they're not oxygenating, or they're hyperventilating. Just like, remember I showed you the case of just the diaphragms being shoved up. That person's doing rapid breathing. He's moving a lot of air, so the CO2 will be low, but he actually is in respiratory distress. So, and when we talk about normal entitled CO2, it's sure, we like it to be in the 30, 35 range for most anybody in this room. There's other times when it being lower is a good thing because we've got a good reason to be working harder and dropping it down lower. And it's something that we want to trend. It's the trends that are especially important. Julie first.
Well, you kind of answered that just my question just now. But,
Okay.
so, but then how are we supposed to differentiate that then? I mean, if they're, in that case, they're reaching that normal range, so our only indicator then is their body language? Is that?
No, okay, so this is like, I'm so
See
glad
what
you
I'm
asked
saying?
that. So
That's
this is
the
really
perfect
confusing.
question. I'm
So
glad you asked
the first time we reviewed this, it was really hard for me to wrap my head around this because when you look at the strips from that call, like you said, the trend was going up, the numbers were going up in actually a really short amount of time, so it was going up quickly, yet she was hyperventilating, so it really shouldn't have been going up. So I was thinking, oh, she's not that sick because they're going into the normal range. But then when we talked about this, like, okay, yes, the 35 to 45 is normal, but she's trending in the wrong direction for what she should be doing, which equals sick.
So it's unlike O2, where always, higher oxygen, PO2 sounds good, okay, the ROS, somebody should be improving. With the CO2, it's a measure of ventilation. And so when somebody's CO2 is too high, they're not ventilating adequately, okay? They're like the COPD, who's just used to just letting my CO2 level go up. When it's somebody where it's lower than that, what's normal, it means that they are hyperventilating. They're actually increasing their ventilation. Why are they doing that? It could be because their airway's obstructed. It could be that they've got an airway burn. It could be they've got pneumonia. There's a lot of other things that will make us hyperventilate. And so you've got to look at the big picture. So again, when we're reviewing this case, I'm going, everybody looking at the numbers going, oh, that looks good, they're getting better. And me, I'm getting sweaty hands. I'm like, no, I've been there before. This is somebody who's going to crash on me. That climbing CO2 is actually a very bad thing in somebody who we know is working hard to breathe. You want to see their CO2 staying low.
So that was my question. It wasn't that the number was going up, it was the number going up in conjunction with the fact that their respiratory rate hadn't gone down. Is that the best way to?
Or even staying the same, okay? Or the respiratory rate's increasing and still their CO2 is going up. So Jenny's getting back to the key point. It's the trend. It's what it's doing. It's not necessarily where you start at. It's which way it's going.
But if in that if in that case their respiratory rate started to improve and their work was decreasing, then it's okay,
Oh, then it's
right?
okay.
Then we're all good because
Right.
we're all talking normal people now.
But also the waveform will give it away.
Then we're normal people.
If the waveform starts to flatten out and square off, then it's suggesting that they haven't got that, that resistance.
Very good. Yeah.
But does an asthmatic in their normal state, they're, like, say you have a person that has asthma since their youth, but they're not having an asthma attack, is their normal waveform still shark shaped?
No.
Okay,
No, when their asthma's completely under control, no.
it's not.
Somebody who's got
COPD,
that's why they
on
call
the
it
other hand.
chronic obstructive
Yeah.
pulmonary disease, they pretty much always will have a sharp
Okay.
form. Okay, they have a hard time. That's why they're doing that pursed lip breathing all the time. What they're trying to do. I know I'm going back to physiology you've all learned before, but pursed lip breathing, what you're doing is giving some back pressure because you're actually trying to blow up the little bronchioles that are collapsing, make them inflate a little bit more so you can get air out. It's a weird physiology, but by pursed lip breathing, we can actually get out air. They can get air out better because they've got bronchioles that collapse. And so they'll have the sharp form all the time, but the young asthmatics who've got reactive airway disease, they've got those hypertrophic muscles in their bronchioles that can go into spasm from many different triggers. They're the ones that can die on you real quickly when they get a really severe attack.
So back to the asthmatic case we were talking about, so assuming that, I don't know the call, but assuming that the medic was giving albuterol, the patient was on CPAP, he'd given epi, that he's doing everything he can, is there anything else that they should be doing other than just looking at that and going, oh crap, I hope I get to the hospital soon and have my intubation kit out? I mean, really, was there anything else that, I mean, obviously he didn't recognize the number issue, but was there something else he should have been doing?
Well, yes, yes, and yes.
Okay.
All the things you've just said, but this is an experienced medic talking here. You know, should she have gotten epi in the field? Yes.
So in the
Just
first
something
case,
who was-
in the first instance and they've gone on her since, after learning about this, in that first case, they did not give the epi.
Oh.
So they didn't really, they were thinking kind of what we all were thinking, like, oh, she's going in the right direction.
Right, okay.
And so after we talked about this, Dr. Giorgio explained how it's sicker, not better.
Right.
Be really aggressive with the epi. I think they went on her like 2 weeks later, same scenario, and they were really early with epi administration, and she had such a different presentation upon arriving at the ER than the first time.
Okay. But assuming that you have gone all, like, kind of exhausted, I mean, I guess you can try and get orders for epi 1 to 10, IV, and you can go that route, but is there really anything other than intubation at that point and like salbutamol and things like that are gonna reverse what's going on, or?
No, intubation, you know, an asthmatic is actually very hazardous.
Bad, right.
You know, right? Because we get lots of barotrauma. A lot of studies have shown once you intubate a patient with asthma, the mortality rate goes way up. And sometimes you're just forced to because they've pooped out. She was reaching the point of exhaustion, or just fatigue. Your intercostal muscles are exhausted, your diaphragm's pooping out. And that's when they start losing it. So how many of you have, you know, had your CHF patient, you know, that starts pulling the mask off and they're panicking, or your COPD, or that I hate it when they do that because it's telling me something. And the problem is, I mean, not to be prejudicial, but you know, a young female, I think it was easy to get in the mindset of, oh gosh, you know, we know her well, she's a chronic flyer, you know, that this is, she's just being hysterical or dramatic about it. You know, this is those are the ones that I've gotten burned on. You know, whenever I dismiss somebody as having a hysterical reaction, you better think twice. So I wanted to come back and just give you a little different case. There's so many different presentations where this syndrome of a low CO2 is perfectly appropriate for the condition that they've got. And the trend, as we just talked about, is so critical because that CO2 will help us recognize early on when they're decompensating. Now, I was hoping we'd have a chance just for a demonstration of the lag. Okay, sorry, I'm a little bit long-winded. Again, they are and we'll
They are,
still use
because I've
them.
argued with many years after.
And maybe half the oxygen that they need. What's your O2 set look like on some of your carbon monoxide?
100%.
It's 100%, that's right.